is this the first inaugural lunch and learn with the docs?
With the docs,
Yeah.
Mhm.
All right, well, good. Well, thanks for coming, and I want to keep it pretty low key. When Savory asked if I could do this, I thought initially just about working up, patient in the anterior segment and cataract patients, but it seemed like that was a little too small a focus, so I decided to, just to kind of get a good amount of time here, I expanded it a little bit, and if we're running out of time, Savory, just cut me off.
Okay.
So I'll just maybe if I can just give you the next slide.
Okay.
So in this slideshow I put together out of a couple of different slide presentations, including one that I gave to the JCHAPO a few years ago.
Yep.
So hopefully it'll be cogent going through it. And like I said, any questions that come up with any of the slides, let me know. Just ask away. Come on in. And some of the slides I might just kind of skip through a little faster unless you have questions about it. So next slide. So what I thought, next slide. What I thought we'd talk about, next slide, is first talk initially about some workup points for cataract patients in our clinic over on that side of the building. Talked about optimizing the happy factor for premium IOL patients, which we have a lot of these patients that come through. Talk about outcomes for patients with some of the premium lenses that we use here and some of the extra stuff that you see here in this on that side of the office. And then and especially multifocal patients. And we'll talk a little bit about some of the multifocal lenses. It's not the focus of this talk, but we'll touch on some of that. Next slide. So just to get started, our patient population is really changing. It used to be patients would come in and they have cataracts, and we take them out, and then they'd get their glasses with whatever prescription they still had, and they were all really happy. And it was pretty bare bones, and we're kind of the victim of our own successes. Because these days, because we can do so many other things, the patient expectations keep creeping up higher and higher and higher. Next slide. So baby boomers are not the cataract patients of old. It used to be they were retired patients. Well, they're usually still retired patients, but baby boomers today that are kind of the prime group getting cataracts now are still active. Many of them are still working. They play tennis, they go hiking, they ride their bikes, they do all this extra stuff, and they're really looking for the best vision they can get. And just, funny slide here, 7 per minute people are turning into baby boomers this year. Anyways, next patient here, or next, turning 65. So every patient that comes in here for a routine exam basically is a potential cataract patient or YAG patient or some sort of surgical procedure. And I'm not going to talk about all the anterior segment procedures that are done. I'm just going to focus on cataract surgery here today. Next slide. So when these patients, even routine exam patients come in, it's important that I have all the information I need, or Dr. Smith or Dr. Mayer or whoever is seeing these patients, or Dr. One of the glaucoma docs even. And these patients, if they are in that category, and I'm saying over 55, because we have plenty of patients over 55 that come in for routine exams, but they have vision complaints that aren't just explained by a change in their prescription. So the information, the bare bones information that I want to have is MR, AR, some sort of keratometry readings, and a bat. Okay? Even if they've had cataract surgery, I still want to have a bat on these patients. So next slide. So talking about bat, how do you check a bat on a patient who says they have, or how do you justify checking a bat on somebody who says they don't have any complaints? They come in and I see fine. Well, you ask these patients, do they drive? Well, I drive. Well, do you drive at night? A lot of these patients don't even drive at night. So how are they going to see glare if they're not looking at headlights? Okay, it's an issue. And many people who scribe with me have seen me shine a flashlight in their eyes and cover one eye. Do you see that fine pinpoint of light, or do you get a glow around that? Well, that's glare. So, you know, it's important to, when you're working these patients up, to talk to them about ADLs, okay, activities of daily living. And, you know, of course, you have to talk about driving, lights at night, but not just outside when you're driving, you know, walking down the street, you know, the overhead lights, lights in their house, you know, they can see halos around the lights in their house. It's important to have them talk about computer, you know, reading, TV. Those are all things that all these people look at. And, you know, sometimes if they're with a spouse, you can ask the spouse, are they squinting at that TV, or are they complaining? Because a lot of times they're not going to tell you really if they have complaints, but their spouse will say they complain every day about this, that they can't, you know, they can't do something. They're having trouble tying flies, or they're having trouble, you know, with golf, or, you know, one of their sports that they do. And the other issue is double vision. Sometimes they say blurry vision, but they're really complaining of double vision. And, you know, monocular double vision is a sign of cataract. So you have to ask them about their visual symptoms, and if they have no visual symptoms that they're admitting to, press them on those kind of issues. Okay? Just a quick question, any strange visual symptom that somebody's had, that they didn't have any glare, but they had problems doing something?
Computer screens.
Computer screens.
Mm-hmm. They have to pull up the font, make the font bigger on their computer,
Or
just to see it.
inside restaurants, sometimes we do.
Menus, exactly,
Mhm.
yeah. So, yeah, I mean, there's a million different things you can ask about it, and I know you have a limited amount of time, so you kind of want to go for the money questions, as I said. Okay, next question, next slide. So, a lot of these patients have no visual complaints, but then you can't get them to 20/20. So that is a reason to check that, okay? And it's not always cataracts, you know, oftentimes it's ocular surface. In our dry climate, so many of these patients have dry eye, and that's a huge reason for somebody to have an issue that's not a cataract. And of course, all the other parts of the visual system through the cornea, lens, vitreous, retina, optic nerve, and brain. And when I say brain, I'm not talking about somebody who's had a stroke, or which that obviously can be a big issue, or, you know, glaucoma. But a lot of patients actually just don't have a 20/20 brain. It's no other way to say it. You know, they just can't see the 20/20 line, whether through dementia or some sort of other neurologic issue. So when, you know, the old tenet that will under promise, over deliver, it doesn't apply to just the surgical procedure. It applies to their experience from when they sit down in your chair to when they leave my chair. And it's not just me talking to the patients, because I know they're talking to all you guys before and after I leave the room. Sometimes I'm amazed that, you know, whoever's scribing is still talking to them, and I'm through with the next patient, they're still talking to that patient. So this really applies to you guys as you're talking to these patients. You know, cataract patients can be our most happy patients or our most unhappy patients. And it's not just me or Dr. Smith or whoever talking to them. That depends on your interaction with these guys also. You know, so when these patients are coming in, you know, sometimes you're gonna be able to tell they have a personality deficit disorder. And there are patients who will come in, and oftentimes they're frequent flyers that nobody wants to see them. But you know, sometimes they're gonna be talking to you about something, and then when I get in the room, they are on their best behavior. And so if you see something from one of these patients that is a red flag, let the doctor know about it ahead of time, because that is really, really important. I can't understate the importance of that. You know, because then I don't see the true stripes unless something's wrong on the other end, and then we're trying to play catch up. So if you see something that just doesn't sit right with a personality, you know, don't keep it to yourself.
So what types of things are you looking for specifically, Dr. Olsen? The severe type A personalities that would be great candidates for multifocals, or are there other things that you look for as well?
So, you know, expectations, some patients come in and they expect every cataract surgery is done with a laser, and they're gonna see distance and up close and everything in between, just with a regular lens, so that they don't have to, have any additional costs. We have a lot of engineering types in this town, and if a patient who asks really specific technical questions about the surgery, that's a red flag for me. Okay, not in a necessarily bad way, but I want to know if they come in and say, do you use the excimer laser with 190 nanometers? That's a flag that I want to know, which I've had. That's actually a real story. So multifocal side effects, and we're going to talk a little bit more about multifocals, but these, the basic rule is if a patient knows about a side effect ahead of time, then it's not a complication. If they know that there's a chance that they're going to have halos ahead of time, it's not going to be a complication. Okay, and we'll talk more about that. And contrast sensitivities, that kind of thing. Potentially need for glasses. The multifocal lenses, we don't have a lens that gets all three zones of vision. Okay, it just doesn't exist in this country yet. But stay tuned, it will. And then, biometry, that's, we have the pre-op lab that does a great job here. We need to talk to these patients about their ocular surface, and that isn't just me. That begins with you guys talking about, I see your eyes are really dry. What do you do? Because for your dry eyes, because when patients talk about meds, they almost never say, well, I use dry eyes 10 times a day. Or sometimes they won't even tell you if they're on Restasis or if they're on some dry eye regimen. So that's important to know if they are on or have been on something in the past. So, and then, we're going to talk a little bit more about residual sphere cylinder, how that really impacts these patients. But more importantly, how you talk to them and point that out or not point that out really has a big effect on the 20 happy outcome. And then abnormal topography is obviously important. Go ahead and next slide. Just a couple stats. Almost 15% of patients throughout the U.S. gets a premium lens. Our clinic, I think, is a little higher than that. And when we're looking at a recommendation for these patients, we're looking at regular keratometries, irregular retinal surface, and so a lot of these patients, if there is a history, in the notes, you look at past diagnosis. If there's a history of an epiretinal membrane, it's good for me to know that, And if there is a history and they're looking at cataract surgery, that's maybe a patient that an OCT is a really good option before I even walk in the room. And then again, corneal scars, any other pathology that might be an issue in the dry eye, of course. Next slide. So this is just to remind me about abnormal topographies. Lots of times we'll do surgery on these patients and they'll come in and they have, some astigmatism, and we'll recommend a toric lens or a toric multifocal. And then if we don't have something like this to say, well, this is maybe not a good patient for a toric lens or a multifocal lens, then we're dealing with this afterwards. And then it's not just what they had, now it's our fault that they have this, according to the patient at least. So it's really important that we really have a big picture of what's going on. And, and again, when you're working these patients up, if there's a history of any cornea, any kind of pathology, or you can ask the patient, have you ever had eye muscle surgery? A lot of these patients, they come in and they have a visual acuity problem. This goes back to the 2020 deficit relating to a brain. I've had many patients through the years that we do the surgery, everything is perfect, the numbers look perfect, and they're seeing 20/40. And we can't do every modality for testing, can't figure this out. And finally, and it's something I should have asked earlier, but it's something that you guys could pick up also. Well, were you ever patched as a kid? Oh yeah, I was patched as a kid for my lazy eye, but they didn't think about that for since they were 10 years old. And now we have a patient with a lazy eye and an outcome that's not optimal, but if we knew about that ahead of time, again, it's not our fault, it's just the way their eye is. So those kind of things, those kind of questions are really important to ask ahead of time and through the process so that we're not surprised after the fact. Next question, or next slide. So I did want to spend a couple of minutes talking about the standard lenses that we use. It's just not, we don't just use Acrosoft lenses because we have a good relationship with Alcon and they give discounts on their packs. The lens, we use this lens because I feel like it's the best lens out there, okay? And the Acrosoft platform has been shown to be the best, among the best for contrast sensitivities, low function driving, challenging low contrast conditions. And when we're through the years, when we've looked at all these different types of lenses, people will come in with this lens to try or that lens to try. This is our gold standard that we compare every other lens to. Next slide. So, the Alcon lens that we use, and that's the SN60 standard lens. I know all the initials of these, the descriptors of these lenses can be a little confusing to people, but that's the single focus lens. It's been shown, we have that, it has that blue, low wavelength blue light chromophore in it. And there's several reasons that we use that lens. One is there are some studies that are not conclusively proven, but there's enough proof that it can help reduce the risk of macular degeneration. We know UV light has a direct effect on that, and so all the lenses have UV light blocking. The lens we use has that blue chromophore blocking also, and it's not in the visual spectrum. It's below the visual spectrum that it blocks. But in addition to that, it also has been shown that this blue light filtration in Sudafix shows faster what's called photostress recovery and reduced glare disability results. So that means when you go from a dark room and you go outside and it's so bright and it takes a while to get used to that light, this lens helps you get used to that faster, which is important if you're going through a tunnel or something and then you're bright and then all of a sudden you can't see when you're driving. So this lens has been shown to help that. It's reduced glare disability, better for daytime glare, and there's been actually some studies looking at the safety margins with collision. So it's really the benchmark for us. Next slide. I think I have one more slide, maybe two more slides.
Oh, I thought.
Yeah,
sorry, my bad.
yeah. But it's just been shown to have.
A little tricky.
Yeah, so it's just more of the same. Low angle sun and fog and all that. So this is our lens, and I think all of us, this is the lens that we go to for all of these reasons. So I just put this up there because I want you to feel like the lenses we recommend aren't for a dollar reason. In fact, there's a lot of lenses that we use that we could use that are low cost, that would be less cost to the clinic, but we use this because we believe it's the best for the patient. All right, next slide. But we're always trying to do better than what we have right now, okay? So, our LASIK results are really good, 100% 20/40 or better. Phaco, 75% 20/40 or better. Next slide. If you went to, there was a poll that was done a few years ago. Not a poll, it was a study that looked at outcomes. And if you did a poll of all the ophthalmologists around the country, how well they do in terms of hitting the target. Everybody says we're right on zero correction every patient. We hit it on the head every time. Well, the actual number is ophthalmologists in this country hit the nail on the head, and when I say that, plus or minus a half a diopter of residual sphere. But 70-71% is how often we actually do that. Well, we have a lot of technology in this office and in the surgery center, and what all this technology has been able to do for the eye center is we've increased that number to about 93%. So it's not 100%, but we do way better than the national average for those things. So 92.6%, that's our number. no, that's not our number, but that's a slide I don't think I put on here. But we're about 93% plus or minus a half to half. Next slide. So just to kind of go through a couple of those, I don't know how much you guys know about, Varion, but how does that translate to surgery? I just wanted to put this on here because I know there's some new people, maybe, I don't want you to think it's voodoo over there. It's technology that we're using. So next slide. So we have Varion that Sharon and her team do to great skill to, really get us the numbers that we need to maximize outcomes. And so from Varion, that information goes over to our LensX. Over the next slide. It just basically enables advanced formula IOLs and mapping out incision implantation axis for astigmatism control. Next slide. And this goes over to LensX, and the LensX is this technology that, just for to show also the commitment that the Eye Center has to good vision. In 2011, when this technology came out, there were 12. Well, we were the number 12 office to get this technology in the whole country. Okay, so right now there's about 400,000 eye surgeons trained to do laser cataract surgery, and the docs here in 2011 were in the first 50. So kind of a cool stat. First in the state, and really we've tried to be industry leaders here, just a little over 4 columns. So, but it affects the surgery in a couple of really specific ways. Number one, it makes all the incisions to get in the eye, so we don't have to use knives or blades or scalpels. It makes the capsulorhexis, that's the opening to get to the cataract, with a roundness and centration and precision that no human hand can duplicate. It breaks up the cataract with a laser energy, so there's less overall energy used inside the eye, which is kinder on endothelium and other internal structures. And then, of course, it affects astigmatism, okay? And I'll use this up to about 1.5 diopter of astigmatism to reduce that residual refractive error. All right, so next slide. And this is kind of what it looks like. This is an old slide. Our images are way better now, but that's kind of what I'm looking at when I'm doing the surgery. Just another picture of that. Next slide. So these incisions are really, really nice. So we used to do these with a blade, just a diamond blade, kind of freeform cutting. And now we have very, very high precision, reproducible, limbo relaxing incisions with the right shape, length and diameter, and depth to maximize astigmatism correction, to try to keep chasing after these expectations of the patients. Next slide. So sometimes with all this technology, a patient will still come in and we have a refractive surprise. And so it's like, why, all our numbers say this is going to be a 0 correction. How come they're -1? Or how come they're +3, +0.5, or something like that? Well, and there's several factors. One is what's something called the effective lens position. And that has to do with when we put this lens in the eye, in the capsular bag, it's not always an absolute static place where that heals up. Hit the next slide. Sometimes if that is, if that lens is a little farther or a little farther back, you can just hit the next 3 pictures. It's going to change how the light comes through there based on the positioning of that lens. So that's one reason we can have a refractive surprise in these patients, okay? And, there's some formulas that are trying to do a better job of predicting that effective lens position. One thing we know can have effect is having a very, very precise capsulorhexis that we can produce with this LensX technology can help minimize some of that ELF or ELP or effective lens position outcome. So we're always striving to get better and better with that kind of stuff. All right, so and that's just kind of restating that. So next slide. We also have the Aura system. Okay, Aura is our intraoperative aberrometer. And what that does is it's a technology that when we take out the cataract before we put the new lens in there, it actually measures the aphakic refractive properties of the eye without a lens in it, aphakic. So it helps really significantly in patients who have had previous refractive surgery. You know, when a person's had LASIK or PRK or RK, the formula that we use, which is based on the axial length of the eye and the curvature of the cornea, that cornea is abnormally shaped now. And so our formulas are less reliable. So we can use this technology to measure the eye without a lens to help us get the right lens. So it's just one more thing that we can do to get better outcomes for our patients. So next slide. And it's also helpful for toric patients when we're looking at that astigmatism, because we, you know, when we take the lens out and we measure the eye, it's going to tell us how much astigmatism. You know, we pick a certain lens, you know, and it's going to say, you know, you need a little bit more astigmatism correction or a little less. And then once we get that lens, we put that in and we take another picture, and it's going to say, well, you know, you need to rotate it 5 degrees clockwise or counterclockwise, and so we can really hone in on these prescriptions. So our outcomes are great, but they're getting better and better as our technology gets better. So stay tuned for that as we still get better at that too. All right, next slide. That's just when we're measuring. This is an eye with a lens in there. We get this reticle that says, you know, you're right on there or you're off a little bit. So it's helping us get you know, more LASIK-like outcomes. All right, next slide. All right. So any questions at this point? How are we doing on time? Still okay?
Yeah, we're good.
All right, next slide. So I wanted to talk a little bit about lenses here. So I'm not going to go through all of these lenses. You know, we have several different multifocal lenses that we use. I used to use a lot of crystal lens. I don't use those so much anymore. We still use the Technis multifocal lenses. That's the ZK Boo and the ZL Boo and the ZM Boo, and then the Restore 3.0s. The two newest lenses that we use are the Technis Symphony and the Restore Active Focus lens. And just for time, I'm going to concentrate on the one I use probably the most, which is the Restore Active Focus lens. So go ahead and next slide. So important when you're talking to these patients, because outcomes are really critical, that everybody's kind of on board, that, you know, we're cheerleaders for these patients, that their path, even if it's a little, you know, off or there's a little residual refractive error, they are not outside what the norm is and what we deal with every day. So it's really important for these patients to know that we are correcting 2 zones of vision, not 3. And a lot of patients will do this blended vision where we'll have a distance intermediate lens in one eye and a distance near eye or lens in the other eye, which that little bit of monovision seems to be well tolerated in patients. And just kind of an interesting aside, and this is not just me, but I certainly do this, there's a higher level of using blended vision like this in females than as opposed to males. And it's I don't know if it's 2 to 1, but it's certainly a significant number. And again, as I mentioned before, if the patient expects to see halos at night initially, then it's not a complication. You know, they'll say, yeah, I knew that I was going to see that. It's not as bad as I thought it was going to be. I hear that a lot from patients. Next slide. So this is what these lenses look like. The Restore has 9 rings. The center button in this lens is focused for near vision. Okay. The active focus, the center, is focused for distance vision. And go ahead and get the next one. There's a couple reasons I like using this lens right now. The central portion of this lens is 100% dedicated